So welcome everybody to today's session. My name is Kate Stevens. I'm a nephrologist from the United Kingdom and I will be your moderator today alongside Christoph Wanner, Professor of Nephrology from Würzburg in Germany and of course, as you are all aware, President of the ERA-EDTA. So this is the fifth seminar in our e-series on diabetic kidney disease, and the session is entitled Patient-Centred Strategies to Improve Outcomes for People with CKD, both with and without type 2 diabetes. So it's intended really to be a summary session, bringing together all of our other previous sessions. Many of you have submitted questions, which is terrific, and we've categorised these broadly into 5 areas that we're going to ask our expert panel to discuss. And we've done this in the hope that we can bring something new, and we're not always covering just the same questions, but perhaps giving them a different spin and bringing in some new data. So I'm going to ask our panel to introduce themselves. So first up, we have Professor Katherine Tuttle.
Hello, everyone. I'm Katherine Tuttle. I'm a professor of medicine at the University of Washington and executive director of research for the Providence Healthcare System. And I'm very pleased to join you here today from early in the morning on the West Coast of the United States.
Yeah, thank you very much. It's 8 o'clock in the morning for poor Prof Tuttle. So next we have Prof Hiddo Heerspink.
Hello everyone, my name is Hiddo Heerspink. I'm a clinical trialist, professor of personalized medicine and clinical pharmacology at the University of Groningen in the Netherlands.
Thank you, Hiddo. And Professor Nikolaus Marx.
Yeah, hello everybody. My name is Nico Marx. I'm professor of medicine and cardiology and head of cardiology at the University of Aachen in Germany. And I'm happy to be invited to this faculty. Thank you.
Thank you, it's great to have you. And then finally, last but not least, we have Prof Rajiv Agarwal. Has Rajiv appeared? Okay, so Rajiv will appear and we will introduce him when he arrives. For now, I'm going to hand over to Prof Wanner, who's going to explain a little bit more about the 5 themes we're going to try and cover today in our discussion.
Thank you, Kate. We received a lot of questions. Actually, I counted them. There were more than 20. And we have responded to several of these questions over the past e-seminars, but we always have new guests. And therefore, we thought to include the 17 first and then more than 20 questions into overarching themes. And I will project these themes, what we want to discuss today. And they are here, and you could concentrate on them for a minute. And meanwhile, we introduce the next guest, Professor Rajiv Agarwal. Hello, Rajiv. Do you want to introduce yourself for a moment, what we did with the others?
Sure, Chris. My name is Rajiv Agarwal. I'm a professor of medicine and a practicing nephrologist at Indiana University School of Medicine and at the VA Medical Center in Indianapolis. Thank you very much for inviting me. Glad to be here.
Thank you, Rajiv. So you see the 5 overarching themes to discuss. You do not see the full screen, which somewhat is not working in the moment. Anyway, you can see it. The 5 themes. The first thing is we always get questions about the dip of Sglt2 inhibitors and whether there is harm. Then the new data about glomerulonephritis, which emerged from Hiddo's DAPA-CKD trial, and we will discuss this. And then about diuretic treatment, 3 questions were embedded into the 17, and we need to discuss it in the elderly and heart failure patients, and Nico Marx is here to answer this specific questions, even on diuretic treatment. Always what to do in stage 4 CKD. And finally, the last topic, when we discussed this before this meeting, I was really struck by Katherine Tuttle's expression, we should shine a light onto dark places. Katherine, apologize that I use your words, but I think this is appropriate to discuss that we have Sglt2 inhibitor, GLP-1 receptor agonists, and MRAs in the future. And in the short future, we may also receive the label for appropriate treatment. So you can call them magnificent 3, but are they only appropriate or magic for a couple of rich people in the world? And let's discuss this, whether one time we can reach the stage what cardiologists can do in the moment, give all these important treatment all in 4 weeks. So this is today's topic, and you see that we start with the so-called 2 elevator speeches, actually 2 E's, and Hiddo, you may do your 2 minutes. You have evaluated the dip in the, I think it was the Canvas trial. Maybe you say a few words about the characteristics of the dip.
Thank you, Christoph. Yes, indeed. The dip or the decline in eGFR is very common when we initiate an Sglt2 inhibitor. And initially, this was interpreted as a side effect that could even lead to acute kidney injury. But over time, we have learned that this is a reflection and manifestation of the mechanism of action of Sglt2 inhibitors. They reduce intraglomerular pressure and glomerular hyperfiltration. And clinically, this is reflected by a decline acutely in GFR, just like ACE inhibitors and angiotensin receptor blockers. We analyzed data from the Credence trial to answer the question, what are the long-term consequences in people with a larger initial decline compared to people with a modest or even increase in eGFR after initiation of an Sglt2 inhibitor? And we demonstrated that irrespective of the initial dip in the magnitude of the initial dip in eGFR decline, the long-term eGFR trajectories were consistent. Importantly, whatever dip or change you had in eGFR initially, the long-term eGFR trajectories were always much better compared to placebo-treated patients. Furthermore, the initial dip in eGFR was not associated with a higher risk of adverse events, only in the rare case when the initial dip exceeded 30%. But that was a really rare case and only happened in about 0.3, 0.5% of all patients. So overall, we now know that this initial change in eGFR is a reflection of the mechanism of action, reflects intraglomerular pressure reduction, which is associated also in the long term with protection, is not associated with harm, no safety signals if you have a dip in eGFR, except in the rare case when it exceeds 30% in patients with diabetic kidney disease who were studied in the Credence trial.
So thank you, Hiddo. And I do not need to add a lot. We evaluated the Empiric outcome study, and actually we found similar things. So this confirms what you are saying and assures us that there is no harm. Actually, we evaluated the number of patients as well who have a dip more than 30% or a more than 30% increase in creatinine. I recall the consensus, I think led by George Bakris 20 years ago, how much of an eGFR decline or a creatinine increase can we tolerate before we stop the medication. And more than 30% decline upon Sglt2 inhibitor treatment was very infrequent. And as you say, it was around 1.0. Even in the placebo, you find these dippings, interestingly. And therefore, my question is now to the other experts, whether we should measure creatinine at all. Are we so far that we can say, don't do this because there is no harm and everything will stabilize? Because if we come to this consensus, or could come, if you feel so comfortable, it would make treatment much easier. So give Katherine the preference to start a comment on how do you feel should we monitor our patients after starting of treatment.
Sure, a couple thoughts. So, you know, looking across the various trials at the dip, on average, in absolute terms, it's somewhere between 2 to 5 mil per minute per 1.3 meters squared change in GFR. And I'm wondering if we ought to even look at the absolute change, because that's really a very small absolute change. And one concern might be that in patients with lower GFR, say someone who starts with a GFR of 32 and, quote, drops to 28, that would be, you know, considered a significant drop by a percent change. And I mean, I'm wondering if we ought to really be looking at the absolute change, because I think it's less concerning then, especially people with the lower GFRs. So just a thought for the group. I'm interested in your reflections on that. And that might also seem a little less intimidating to people, because in absolute terms, it's really very small. And I think that's been consistent across the different types of patients and different trials. And I guess the only thing I will say is, like Rajiv, I'm still actively involved in clinical practice as a nephrologist and also as an endocrinologist. And the only times I guess I think this rolls up to the diuretic question. I have seen several patients where the serum creatinine or the GFR, you know, fell substantially more than, say, 5 mil per minute. And in those cases, it was usually due to volume depletion in people who were diuretic treated. And the management of it was just to simply reduce the diuretics, and then their kidney function came back to baseline. But I'm wondering, especially in diuretic treated patients, if we still do need to check somewhere, as you've said, 1 to 3 weeks afterwards to make sure that volume status is appropriate and that this isn't a reason for the decline in GFR. So those are just a few thoughts in response to yours.
Yes, so I think that those are very interesting points. Nico, would you maybe pass comment about the diuretics? What do you think?
Of course. So we have experience with these drugs in patients with diabetes and different eGFR. In our country, it was only approved for the treatment of diabetes if the eGFR is above 60 to start. So in our experience, we initially checked the creatinine, but then having seen the data and having included patients with a high GFR, we stopped that and never run into problems. It's a little different in heart failure patients, because these patients, you can start in this country dapagliflozin down to an eGFR of 30, and most of these patients have loop diuretics. And if they are recompensated and the loop diuretic dose is not too high, we stick to the dose, but then would check the creatinine or the eGFR after 3 weeks. So in other words, it really depends on the population and the eGFR you're starting with. But based on what Hiddo just said and what Christoph said, the key question is, do I run the risk that a patient develops acute kidney failure? And if this is not the case, I would throw the question back and say, why checking then? And not only looking at the patient from a clinical perspective, and if he's dehydrated, just reduce the diuretic.
And Nico, I think you're making an excellent point. When we check the creatinine after initiation of an ACE inhibitor or angiotensin receptor blocker, we do that in part because of a potential risk of AKI. With Sglt2 inhibitors, we actually know that Sglt2 inhibitors reduce the risk of AKI. That may still be different for individual patients. For example, the older patient who is on a diuretic and has heart failure, that individual may be still at high risk, but at a general population level, these drugs reduce AKI. So from that perspective, I don't think there's a need to check creatinine values, but I'm also interested to hear Rajiv's and Kathy's opinion on this.
So, I'm struck by the incidence, 0.5% of the people having a 30% or more increase or decline in EGFR.
Yeah.
I think at a population level, that's not insignificant. 1 in 200 patients translated to millions of patients, significant. But that's not the major point I want to make. When you're looking at clinical trials and you're looking at AKI in terms of EGFR change, what it means is that the patient has to come to the outpatient center, have a creatinine evaluated, have an EGFR estimated, and then you can measure the EGFR decline. That patient is very different from the acutely ill patient in the hospital who cannot go to a medical center to have a central lab creatinine drawn. That patient is not included in any of your analysis, Empiric or Credence. They don't have central labs. AKI is a condition that we diagnose in the hospital, not as an outpatient. And in those individuals, I've seen many patients in my practice who come in, who have an acute illness, who are on an Sglt2 inhibitor, and they have AKI. And those patients, we have to be careful. For example, if a patient is septic or hasn't gotten an IV contrast or has gotten volume depleted and is getting an Sglt2 inhibitor, I've often suggest that, hey, let's hold this for a while. We can resume this when the patient is discharged. It's not to say that, I'm not debating the point that we shouldn't stop the drug for a small decline in EGFR. And if people are doing it, they should move away from that practice. I'm just pointing out the fact that when the patient is acutely ill in the hospital and has a real AKI, which is evidenced by tubular damage and not just a hemodynamic change induced by Sglt2, I think it's prudent to hold the drug.
And I guess my comment would be, Rajiv, I agree with you. And that's why we have the sick day recommendations, that these drugs be held with any cause of hospitalization before procedures that are done, particularly interventional radiology or surgical procedures. And then even at home, if a patient has a viral illness, we recommend that they hold the drugs during that period of illness for the reasons you've said. And I guess I would reflect on, I think, when we're trying to move toward better implementation of effective therapies. So I do think we need to be very practical and do it in a way that is not difficult or expensive. So, maybe the approach is really a more targeted group of patients where we do measure the serum creatinine. So, in people who have relatively well-preserved GFR, who do not have heart failure, it may not be necessary. I think in, perhaps the heart failure population, as Professor Marx talked about, or maybe in our nephrology practices where we have people with advanced CKD who often have concomitant heart failure, who are already on high doses of loop diuretics, or, in my clinic, sometimes they're on 3 diuretics. They're on, an MRA, they're on a loop diuretic, and they're on a thiazide for synergy. Those are people that I think we probably would select to bring back and recheck. Again, GFR, but, I would also make the case as a nephrologist, we want to look at electrolytes too, because anytime we add another drug that's going to increase diuresis, there's always the potential for a number of things to happen. But I think perhaps what we need to do is be more targeted and thinking about Hiddo's inspiration around personalized medicine is really do it based on the risk of the patient. And that could be selected patients and not large groups of patients who are lower risk.
Yeah,
I think you're Kathy, right, just Kathy. To add to your point is that if we are holding the drug, we shouldn't forget to resume the drug as an outpatient. And oftentimes we hold the drug and we never start it.
Yeah,
and
really
that's
important point.
Big lesson from the ASARB story too. And I think that's one of the reasons that ASARB use is low is they get stopped and they don't get restarted.
And Kathy, I think that the 2 publications that are now published from the Empiric and Credence trial describe risk factors factors associated with an acute fall in GFR, including diuretic use, heart failure, older age. So if people are interested, they can read the 2 publications and have an idea what population you are talking about if we want to target a measurement to a certain subgroup.
So a consensus for personalised individualised treatment and looking at particular high-risk groups like patients with heart failure. Do you think there's any merit in asking these patients to slightly relax their fluid restriction? So if they're on a strict fluid restriction, do you think that's dangerous? Nico?
So sorry, your question is whether we should ask them to restrict fluids or not?
No, I'm asking whether or not in patients who've got heart failure on an Sglt2 inhibitor, do you think that it would be a risky strategy to ask them to relax their fluid restriction?
I wouldn't recommend that. If you look at the heart failure data, and we conducted a study, and Hiddo published a very nice paper recently on the effect of the acute EMPA study in heart failure. I think stick to the rules, stick to the restrictions, and add the drug. You see an incremental increase in the diuretic effect, and don't relax it, because if something happens, it's very hard to bring them back on the former rules. So stick to the 1.5 liters and don't fool around with that.
Yeah.
So I just want to add to that, in my patients, I never restrict fluids, I restrict sodium. Because fluid restriction is for hyponatremia. When we are trying to control volume, we always tell them to go on a low sodium diet. So fluid restriction, we don't do unless patients are hyponatremia.
Okay, sorry, I have to kick in here. From a cardiologist's point of view, in heart failure patients, the world is a little different. Sorry.
Well, I'll just jump in with one additional comment. While we've talked about risk mitigation for volume depletion in people who have severely impaired cardiac or kidney function, the truth is that more commonly than not, we're fighting volume overload, in which case the Sglt2 inhibitor is our friend in terms of getting better control of volume. And I would say that's the vast majority of cases, to be honest with you.
Sure, and so for cardiology and nephrology, we would not ask people to relax their fluid or their sodium restriction. We're happy with that.
In most patients, right, we're still dealing with excess, not depletion.
So what you did and discussed already covered question number 3, and the only thing is that you missed is the upcoming climate change. Anyway, I had an interview with my brother, who is a general practitioner, and who he told me what you folks are discussing here is pretty complicated, and this worried me a bit. So my question to Rajiv, and now switching totally gears, you are the top expert from the finerenone trial. Do you think that this medication is coming in a little bit easier, and or do we await similar questions there?
Christoph, I think that I don't know if it's easier or harder. What I do know is that it's a wonderful additional medication for treatment of people with kidney disease and type 2 diabetes, right? The challenge that we have to face is how do we provide access to millions of people who have type 2 diabetes and kidney disease? And I think that is going to be the challenge. My feeling is that if we used 3 medications in combination, ACE-ARB, SGLT2, and finerenone, I think it will provide the best value for our patients, not just in terms of relative risk reduction of kidney failure and cardiovascular endpoints, but also mitigate the risk of hyperkalemia that we see with the finerenone molecule. Hiddo has shown very nicely that he's reviewed this literature pretty thoroughly, that when you use SGLT2 inhibitor, the hazard ratio for hyperkalemia is 0.8 across the trials, no matter what trial you look at. And Hiddo has looked across all the SGLT2 inhibitor trials. He found the same thing. We just 2 days back, we had a late-breaking clinical trial at ISN, World Congress of Nephrology, where we showed that if you had exposure to SGLT2 inhibitor at baseline, the hazard ratio for hyperkalemia in the Fidelio trial was 0.45. It was much more than the 20% reduction. So it's a 55% reduction. We have to take it up with a proverbial pinch of salt. I hope we are not taking too many pinches of salt. But I think that only 5% of the patients here were on Sglt2 inhibitors. So nonetheless, it sort of is a proof of concept that when you use the two drugs together, you can potentially mitigate the risk of hyperkalemia. If we do that and provide access to lots of patients, I think we can really turn the corner here for people with type 2 diabetes and kidney disease.
I think, Rajiv, you make an excellent point, and I believe that this is going to be the future, trying to identify the best combinations of drugs. And indeed, how nice would it be that we can mitigate an adverse effect of one drug by adding another drug, and then at the same time maximize protection. It's sort of a similar approach if you think about the endothelin receptor antagonists, which are now in development for non-diabetic CKD, and if we could add an Sglt2 inhibitor, thereby abrogating the risk of fluid retention by adding an Sglt2 inhibitor for the treatment of glomerulonephritis, our second point on the agenda. So I foresee a really nice future to try to find these best combinations for individual patients, and I hope we have now set the stage for this future and can work on this in the next couple of years.
But if you want to see the future, Hiddo, do you need to wait until all these beautiful interventions become generic, or could we do something different to bring this to the patient?
And are you referring to affordability of drugs and costs and reimbursements? Because in some areas in the world, even in Europe, these drugs are not affordable.
Yes, I'm floating over to number 5, which is these magnificent 3 interventions. And before this meeting, we discussed with Katherine, and maybe she can repeat about the situation in the US and how can we improve this before the drugs become generic. Katherine, what is the situation in your database?
Sure. So I'm the principal investigator on a study called Cure CKD, which is a large electronic health records registry of people with chronic kidney disease and people we consider at high risk. So all people with diabetes and hypertension. And we have data now on about 3.5 million people followed since 2006 with a median follow-up of about 5 years. And so we can use that for a lot of indicators, at least about what's going on in a large US healthcare system, which we think is representative of the country. And even as recently as December 31st, 2020, we only have 4% of patients on Sglt2 inhibitors and about 3% on GLP-1 receptor agonists and just 1% on MRAs. And, I think that there still are a number of barriers to actually delivering these fabulous interventions at the point of care. And, some of them are cost and insurance based, but some of them are also that most of these patients aren't in specialty practices. Most of them are in primary care. And I think there's a real opportunity, one, about education of both patients and providers that these medicines are available, that they save lives, and among the living, they prevent heart failure and kidney failure. And that's an extremely important piece of this. And when we look at ACE-ARB use, I'm happy to say that since the paper we published in JAMA about 2 years ago, we've seen an uptick. We're now close to 40% as opposed to 25% use, but that's still really low. So I think there are changes that need to be made, even in terms of the way practices are structured. I know that in other parts of the world, even in different healthcare systems, there are similar problems. And Christoph, I think you alluded to it by your conversation with your brother in primary care, who said this is just too complicated. And, you know, we can learn a lot from the ACE-ARB lesson. I mean, we heard about a couple things. One, the drugs get stopped and they don't get restarted. So that's part of the reason utilization is low. In primary care, people are worried about the change in GFR and how they manage potassium. And a lot of them don't recognize that these have unique kidney and heart protective benefits beyond other agents that are easier to use. And then I guess I'll wrap up by saying this is something Kate asked me earlier. I saw a patient in clinic yesterday with type 2 diabetes and CKD with a low GFR, but not too low to use an Sglt2, but too low to give her metformin. And I tried to prescribe an Sglt2, and even after her insurance, her co-payment was over $300 a month, whereas her glipizide was $4 a month. She's on 16 other medications. She is on a Social Security pension, and it's just completely out of reach for her. So those are some of the realities that I imagine our listeners are facing too. And so what I had talked about with our panel beforehand, I don't know what all the solutions are, but I think we need to shine a light in this dark place. Because if we look and we see it, that's the start to solving the problem. And I'm sure that intelligent, committed people will find solutions. But we first have to recognize that as wonderful as this is, very few people are actually receiving these therapies, even in high-income countries.
So before I go on and ask a question, we are progressing pretty well with our question. And Kate, do you have the oversight of the chat and maybe our other question that later on during our discussion, I think we can also come to the question of the audience, and I encourage the audience also still to send in some specific questions.
Yeah, so we've got four questions in the chat actually. So one of them is pretty straightforward, so I'm going to put it to each of you. So Rajiv, first of all, what's the lowest EGFR you would start an Sglt2 inhibitor at, and when would you want to stop it? At what GFR would you want to stop it? I suspect your answers will all be similar.
Yeah, so, you know, lowest is 25, and that's based on the DAPA CKD study. And in our hospital, we will get approval if the GFR lower limit is 25. We don't stop the drug. We keep going till the patient is on dialysis.
Okay.
At that point, you can discontinue the drug, but we don't. But in stage 4 CKD, you know, I'll take off from what Christoph was asking and what Kathy was lamenting on the affordability issue. So 5 years ago, we actually designed a trial looking at people with poorly controlled hypertension and stage 4 CKD, and asked the question whether chlorthalidone would work in those individuals. It's a double-blind randomized control trial using ambulatory blood pressure monitoring in these patients after a 2-week placebo run-in, and they're randomized to one of the two drugs, a chlorthalidone or placebo. All of them have treated poorly controlled hypertension. And we should have those results soon. The cost of chlorthalidone for 3 months is less than a price of a Starbucks coffee. So it's everybody can afford it the world over, especially the low and middle income countries. And that was part of the motivation of doing the drug, because every guideline says that use a loop diuretic when your GFR dips to less than 30. I'm still blinded. I don't know the results yet, but I think that that would be something that should be on everybody's radar screen. It should be coming out soon.
Okay, so to summarize then, for the EGFR, you would start it down to an EGFR of 25, and you would not stop it until they were on dialysis. If they were on dialysis, would you continue it?
I don't see a value of continuing patients on dialysis. And,
Okay.
you know, there's a question that we can debate. We don't have any data. In Credence trial, for example, we discontinued the drug when the patients went on dialysis. And, you know, similarly, for example, thiazide-like diuretics probably wouldn't work in people with end-stage kidney disease. In fact, Dr. Brater, who was our dean at Indiana University, he has done some seminal pharmacology studies to show that in people with GFR about 20 or so, you need massive doses of loop diuretics to elicit even slight natriuresis. So we typically don't use these drugs in people who go on dialysis.
Okay, and
we cannot compare diuretics directly with Sglt2 inhibitors. I think it's so we still don't know if Sglt2 inhibitors are going to be effective in dialysis. There will be a couple of studies that are going to look at this question, and these are important studies. In contrast to Credence in the DAPA-CKD trial, dapagliflozin was continued while people were on dialysis. There was no increased safety. There were fewer deaths in people on dialysis receiving dapagliflozin, but these data should be very cautiously interpreted because it's not a randomized comparison and the numbers are low, but maybe hypothesis generating, and future studies will hopefully tell us a little bit more about the effects of Sglt2 inhibitors in patients who are receiving dialysis.
Kathy, do you have any comments about the use of these in dialysis patients?
Well, I guess a couple things. One, just a reminder that the studies with Sglt2 inhibitors in chronic kidney disease are continuing in the Empiric kidney study. And in that study, people are enrolled with an eGFR as low as 20. So, we may see that continue to move lower depending on the results of that study. And I don't think we have data in dialysis patients, so I can't really add beyond what Hiddo has already said, except that I would like to change the paradigm in nephrology of thinking of dialysis as a destination. With the marvelously effective therapies that we have, and the earlier discussion about how combination therapies may be synergistic from a safety standpoint, I think it was already said, but I want to emphasize they also may very well end up being synergistic from a treatment standpoint because they work very differently. And we know that diabetic kidney disease, but other forms of chronic kidney disease have multiple mechanisms. Many of them, irrespective of the initial injury, lead to final common pathways. But I would like to imagine a world where we use combination therapies and we're not talking about pre-dialysis or dialysis because it's not a destination anymore. So again, my aspiration is dialysis is definitely plan B. And I would like to think of a world where people stay alive and stay with functioning kidneys and, Professor Marx, healthy hearts too.
Yeah.
Yes, so that would be awesome, wouldn't it, if we could achieve that? Nico, would you like to add anything?
Yes, I think the only point I'd like to add is that in the Emperor reduced trial, people were allowed to be enrolled down to eGFR of 20, and there was no safety concern. So, Katherine, what you said about Emperor kidney, I think we already have data down to an eGFR of 20. And with respect to cardiovascular benefit, if you look at the subgroups, small numbers, I know, but there seemed to be a similar benefit, if not a higher benefit in low eGFR range.
Yeah, so I guess we're hopeful that results might be promising, but we need a bit more data before we could say anything conclusive in patients with GFRs below 20 and on dialysis. Yes. Would that be fair summary? Okay, and then so I'm just going to ask this very quickly. So on the chat, asking about cutoff values for GFR with ACE and ARBs and not continuing them. So I think we probably would all agree that we probably wouldn't stop an ACE or ARB unless we suspected that it was causing an AKI. Would that be fair comment? Speak now if you disagree.
I agree with you, Kate. And remember, again, circling back to the cardiovascular issue, is in addition to preventing kidney failure, we need to be very focused on reducing cardiovascular events and death, and especially heart failure and advanced CKD. Because honestly, if you look at the data that are available, death is going to outcompete progression 2-to-1. And most of these people are exiting with cardiovascular causes. So even if you don't think they're kidney protective, the agents that we've talked about, be they SGLT2s or ACE-ARBs, should be continued because we know they're very protective in terms of cardiovascular events and cardiovascular death.
The cardiologist couldn't agree more.
And Kate,
but then, yeah. Hiddo,
Okay,
go on.
some patients do not tolerate an ACE inhibitor or angiotensin receptor blocker, and sometimes the question comes, can we initiate an Sglt2 inhibitor in the absence of an ACE or ARB? And my answer is yes. And we have data from the cardiovascular outcome trials. Although the majority of patients in these trials had a good renal function, still the effect on kidney function was also present in people who were not using an ACE inhibitor or angiotensin receptor blocker. So I think it's fair to initiate those drugs if a patient doesn't tolerate an ACE or ARB.
But not yet below a GFR of 25.
But not below GFR of 25, indeed.
Okay, perfect. Christoph.
I just wanted to ask Professor Marx, who is living in an ideal world where everything is available in Germany. Recently, cardiologists, the heart failure people, they introduced a new concept where we could go in nephrology in a couple of years when we are living in this ideal world. They told us all in 4 weeks. So what is the concept behind this?
Yeah, so the current algorithm for the treatment of heart failure published by the European Cardiology Society in 2016 has an algorithm. You start with an ACE inhibitor, ARB, beta blocker, then MRA, and then eventually an ARNI. And this concept was based on the clinical trials because the ARNI trial, for example, was done on the base of MRA and beta blockers. And so, but then the EMPEROR-reduced and the DRPHF data were published and showed that the benefit for the Sglt2 inhibitor group was independent of baseline medication. Also, some of them had ARNIs, some of them had ACE inhibitors. And so the concept is that these life-saving drugs, ARNIs, beta blockers, MRA, and Sglt2 inhibitors, should be on board as soon as possible, because we know from the Kaplan-Meier curves with all the limitations that the effect, for example, with respect to heart failure endpoint kicks in already after a few weeks. And same holds true for ARNIs, for example. So the current concept, and we don't have the updated guidelines yet, is start early and try to have everything on board within 4 weeks. And in my clinical practice, we use these drugs pretty frequently, and we started to initiate Sglt2 inhibitors and ARNIs and MRAs very soon, and it worked out pretty well. But this is, of course, not controlled studies, but just our experience. So I can just advocate and encourage nephrologists also to not wait for the next 5 years to adopt such a concept.
Okay, advice taken.
Christoph, that's what you wanted to hear.
Professor Marx, I have a question for you, and this is on the implementation side. I think we've had some earlier discussion, despite the fact that, we've had guidelines too, especially regarding ACE-ARB use for over 20 years, but the uptake is still low. It seems that in cardiology, the uptake has been better. How can you advise us in terms of better implementation of therapies?
Catherine, excellent question. And I had a lot of discussions with Christoph and other nephrologists because this obviously is an issue. Cardiology is a field where we had for decades very good evidence basically for 80% of what we are doing. So cardiologists are trained and know how to look at the evidence and then realize that this needs to be implemented. And I think this is a lesson that needs to be learned. In nephrology, I realized that until finerenone and the Sglt2 inhibitors came out with their data, you didn't have new evidence for the last years or even decades. And this is different in cardiology. And I think it really helps to communicate the mortality benefit and then really make sure that you have concepts, guidelines. We have a very good concept, which is called Get with the Guidelines. Really ensure that everybody knows the evidence and learns to implement it. In our clinic, we provide simple tools. We have a white coat card, for example, where all the indications, contraindications, potential side effects for Sglt2 inhibitors, GLP-1 receptor agonists are written on the card, and every resident, consultant, and even head of department carry that with them. And that really helps. So it's the tools, it's the communication, and then a clear strategy to get with the guidelines.
Yep, absolutely.
And the role of the heart failure nurse?
That's a very important point. We also implemented this concept that not only the physicians, but also trained nurses take care of the patients. But this is also something that you could probably adapt, because you have nurses dealing with, well, it's only dialysis. I think you don't have CKD nurses. I don't think so. Or so the heart failure nurse concept was really helpful.
Okay, so can we go back to asking some of the questions that we've been asked? So I'm going to ask Rita Burns' question, because at the end of her question she has said, "You're all awesome, thank you so much." So that's nice feedback for you. She'd like to know how you explain weight loss with Sglt2 inhibitors in patients with low GFR. Is it just volume optimization, or do you think that there's fat loss? So do you think there's body mass loss as well as volume loss?
I think it's a combination of the two, Kate. I think that the initial body weight loss that we see is a fluid loss. And then over time, during the subsequent months, the body weight loss that we observe is probably because of calorie loss and fat loss. And the reason why I believe that is because in one study, a diuretic was compared with a Sglt2 inhibitor, and during the first weeks, the body weight loss was the same as with the diuretic, but then over time, there was more body weight loss with the Sglt2 inhibitor, whereas the diuretic body weight loss plateaued over time. So I think that during the longer treatment, you see a reduction due to glycosuria and calorie loss. We also see that with the Sglt2 inhibitor, the body weight loss plateaus, and I think that's because people start to eat more. Some people say that they feel more hungry, in particular after a couple of months. So there may be compensatory mechanisms involved, and that people start to eat a little bit more to compensate for the calorie loss. That's my interpretation.
Yeah,
So Kate, let me add to Hiddo's comments. We actually have looked at body composition over several years in people with chronic kidney disease. We just follow them longitudinally with usual standard of care. And we study body composition using a BART pod, which is essentially a body densitometry. You can measure the body's density using an Archimedes principle. Instead of dunking them in water, you dunk them in air, so you know the body volume and body weight, and you can estimate based on that body composition. Because as you know, fat is lighter than muscle. And if your body density is decreasing over time, it means that you're accumulating fat. Now, when we look at these patients longitudinally, it's fascinating because the changes in body composition depend on age, sex, and race. For example, in women, you actually have an accumulation of fat mass, but that inflection point is around menopause. So you basically around menopause, you actually have an increase, but you have an increase in fat weight. In men who are older than 60, they actually lose lean body mass, and they lose it fairly rapidly. So even though you're measuring the BMI is constant, but they're actually converting their their muscle mass to fat mass. And and race is very interesting, what we call as occult sarcopenia, especially in young Black men. What we have found is that they are actually losing muscle mass when they have chronic kidney disease, and you can actually it has an implication for serum creatinine interpretation. It's kind of complicated. We have done it only for 4 years, so it's not like a 10-year or 20-year study, but even over 4 years, because it's an accelerated cohort study, we have multiple ages at baseline, we can be reasonably confident that there are important changes in people going on with chronic kidney disease.
Excellent. Excellent. I think this was the best comment, Rajiv. It goes beyond into the wide field of CKD and what we need to also to observe. Yeah. Kate, you go on.
Sure. So I want to change the focus now to urine. So I'm going to come back to you, Christoph. So we had a survey that some of you filled in, and one of the questions was about monitoring proteinuria. And Christoph and the panel were discussing earlier that we were surprised that most people said that they would use albumin-creatinine ratio. Can't remember the exact proportion, but it was a significant proportion. So we've had a couple of questions about measuring proteinuria, I guess, in these patients. So perhaps we could go to you, Kathy, first of all, to comment on how you would tend to measure the proteinuria in these patients with diabetic kidney disease.
For a number of years, we have not recommended 24-hour urines. And ideally, a first morning or early morning void is preferred for a urine albumin to creatinine ratio because the urine is more concentrated. But really, talking about practicalities again and trying to implement best practices, the truth is that really any spot urine will work with the morning or first morning void preferred. But there's no reason to do complicated urine collections. And, this is something that can't even be collected at the point of care to make it easy for patients. A spot urine albumin to creatinine ratio, morning preferred, but not required.
An albumin creatinine ratio over protein creatinine ratio?
Oh, yes. Protein to creatinine ratio is a historic cultural holdover in nephrology. And honestly, I have no idea why we still measure protein to creatinine ratio. I mean, to be honest with you, for the glomerular diseases, really, we're more interested in albumin than all the other stuff. I have no idea why that is the tradition. I think it's basically just cultural and traditional, and I wish we would just switch to UACR. And I see Hiddo nodding.
Yeah, Hiddo's nodding vigorously.
Here, but to me, it's just I actually find it ridiculous. But I can't. It's like a train that I can't stop.
Kathy, I have asked many people around me, why are we still measuring proteinuria in glomerular nephritides? And then people say, well, it's probably tradition, but nobody has the answer. And everyone says, yes, indeed, it's tradition, but we should measure albumin. I completely agree.
I think it's also cost. You measure urine protein with pyrogalol red, and pyrogalol red or bichichonic acid. Those are really inexpensive. It costs a couple of cents. When you're measuring urine albumin, it's an immunoassay, and you need more fancy testing. So urine protein can be pretty much measured anywhere on the planet. You can heat the urine and put a few drops of vinegar after that. And if it dissolves, it was phosphorus that flocculated. And if it didn't dissolve, it was protein that flocculated. You can do it anywhere in the world. I think in part it might be cost.
That is probably a
But
point,
Rajiv, this concept is taken over also by the rich countries. And if we nephrologists have so many excuses, for our simple kidney test, which is eGFR and albuminuria, we will never win. The cardiologist told me so many times, what is the troponin T of the kidney, or what is, they just use it. They have the anti-proBNP is so expensive. Why can we nephrologists not say, this is our kidney test in those countries who can afford it? And this is albuminuria and eGFR, period.
No, I agree with you completely, Christoph. The issue is that, and Kathy has talked about it multiple times, 1 out of 5 people have urine albumin to creatinine ratio when they have a type 2 diabetes. I mean, it's pitiful how few people are getting tested, yet we grade people on the KDIGO heat map, and you need both eGFR and albuminuria to grade them, right? To put them on the heat map. We can only put people on one dimension most of the time. That's a problem when you're doing clinical trials as well, because we don't have information on albuminuria in most of these patients.
Well, and I think all of the points have been fabulous, but again, I'll speak from a U.S. perspective because that's the health system I know. The UACR test is really inexpensive. It's only $10. So, in some areas of the world, I understand that's a barrier, but, I think to Christoph's point, it's not cost in many countries. It's an inertia around not wanting to measure urine. And also in the United States, there were guidelines that came out from the American College of Physicians, which is the professional society for internists, that some years ago said if a patient was treated with an ACE and ARB, then albuminuria didn't need to be checked because that was the only action item.
Yeah.
Many of us in nephrology disagreed for a variety of reasons even at that time, but it's even more true now, especially as we have this fabulous experience of almost an explosion of new therapies. So I think, again, that's where, to quote Professor Marx, we got to get with the guidelines. You know, if the guidelines say UACR and eGFR, that's what we need to do because that's how we risk stratify people. And the choice of therapies is based on those measurements as well.
Yeah, so there's a comment in the chat correctly that you know, protein creatinine ratio can be converted to an albumin creatinine ratio, but I guess a conversion is not going to be the same as actually measuring the albumin creatinine ratio.
Right, and we were actually involved in that study with the CKD Prognosis Consortium. In fact, a lot of the data for that came from Cure CKD, our registry. What I would say to you is on a population level, that works pretty well. But on an individual level, not so well. And Hiddo, you're really the expert on this. I don't know if you want to jump in. So I would say yes, but I mean, if protein to creatinine ratio is what's available, please do it because it's better than not measuring anything in the urine. But if you can measure a urine albumin to creatinine ratio, that is preferred. And even that has a lot of variations for a variety of reasons. So the closer we can get to accurately measuring the marker that we need, the better.
I think you're completely right, Kathy. At a population level, it works, but at an individual level, it doesn't work so well. So if there's nothing else, measure protein. But if you can measure albumin, start to measure albumin.
Yeah, so proteinuria is better than nothing, but we should be like the cardiologist and follow the guidelines, and so we should be measuring albumin creatinine ratios.
I agree, yeah.
Yeah, okay. Christoph, do you want to jump in? Do you have anything you want to add?
That's fine. I put up this slide, which appears to be the ideal world. Yeah, and this slide says that responded by 90 nephrologists. Actually, the nephrologists apparently who responded to the questions, they do twice or more per year the UACR collection. I put it up for Kathy Tuttle. You did also a paper in JAMA a year ago where you told us it's different in different parts of the world.
Well, and I think, to be honest with you, if you looked at US nephrologists, it would look very much like this. Remember that most people with chronic kidney disease, diabetes, and hypertension, the two major risk factors for CKD, are not being cared for by us. And so remember that the vast majority of people, probably 90% of these individuals, have never seen a nephrologist. And for the reasons I mentioned, in primary care, albuminuria is rarely measured. And that is an opportunity, again, for nephrology to step up and lead on educational efforts for the general medical community and to not be so siloed and to work together with these individuals. Because if we want to eliminate dialysis as destination therapy, we do need to identify patients at the optimal stages when all of these fabulous interventions are going to have the greatest chance of keeping people alive and healthy. And there's one other thing that we mentioned, but I want to come back to this and really, again, congratulate Hiddo and the whole DAPA CKD team. For the first time ever, you showed that we could reduce all-cause mortality in a CKD population. We have never had a therapeutic that did that before. 30% reduction on top of standard of care. And that's right up there with beta blockers post-MI. That's a very high bar to cross. There are very few therapies for any condition that have been shown to reduce all-cause mortality, and particularly by that magnitude. We need to recognize that these are life-saving therapies, and this is a highly fatal condition. And to my test of reason, it is a moral and ethical obligation to be sure that the optimal number of people are treated, whatever that takes. And so I want to call that out because this is really a first. Reduction in all-cause mortality by nearly a third. I mean, if we can't get excited about that, then we ought to ask ourselves why we're doing this.
Mm-hmm.
So
Absolutely.
can you add to wrap up now a bit, add some final words to this plea of Katherine, which actually is already a final plea. Hiddo and Rajiv and Nico, 2 sentences.
Christoph,
Yeah.
before we do that, can we ask just one more question actually from the audience, because it fits in a little bit? So Harold Seeger has said that mortality was reduced in DAPA CKD, so this is for you, Hiddo, mainly via reduction of non-cardiovascular deaths, mechanism not clear. So he's wondering, does that mean that if patients on dialysis who have, as we know, have a very high mortality, should we really be keeping them on the Sglt2 inhibitors if they're on them at the moment before we have firm trial evidence? Would you advocate that? Or do you think we still need more evidence?
We need more evidence for patients on dialysis before we can definitively state that they should be on it. We continued those patients on dialysis. We didn't see more safety adverse events, so it's fair to continue. We don't know if the drug is going to be effective in reducing mortality in these patients. It's a nice hypothesis, but we have to test it.
Okay, so now back to Christoph's point. So Kathy has made her plea very eloquently. Hiddo, final thoughts.
Yes, I would like one final sentence from me. We have studied more than 70,000 people with Sglt2 inhibitors. We have collected a lot of evidence about the efficacy, about the safety of these drugs. And it's now the responsibility of all of us to implement these findings in clinical practice.
And Rajiv?
Well, I think we are in really exciting times that we have such good therapies being discovered and many in the pipeline that we can potentially implement. And this is not limited to the expensive medications, which might take a while for people to use, but also inexpensive therapies like chlorthalidone, for example, in stage 4 CKD. I'm kind of excited about our patients because we should be talking more about, just like we are today, about these data. So our colleagues who are less familiar with the research can listen to these exciting findings and translate it to both protect the kidney and the hearts of our patients with kidney disease. And I have to congratulate Dr. Marx, who has been at the forefront for doing that for patients with kidney disease.
So Nico, the nephrologists are going to give the cardiologist the final word.
That's a great honor. I really appreciate that, my friends. So I think in order to make sure that as many patients as possible receive these life-saving drugs, I think, as said before, make sure that you communicate the evidence, make sure that it enters the guidelines and that the guidelines are implemented. And the last point is, I think, talk to payers and make sure that in the healthcare system, people are aware of these life-saving drugs and that they really need to be given to as many patients as possible. And this concept, I think we try to follow, at least in our country. Christoph and myself have been involved in some discussions. And I think we need to reiterate that as often as possible.
Yeah, so exciting times for nephrology just now. So I think we will wrap up there. I'd like to...
Maybe I give you the word for wrap up, because Kate, you have supported the ERA EDTA with so many webinars, e-seminars. Yeah, you have your own GlomCon as well. You have so many experience. I think it's the point also to thank you to support us always as a moderator in so many things. But from the point of the ERA, I was so happy that we got Rajiv responding to our call and Katherine to come with us and discuss here in Europe. Also, I saw that we have an audience from across the globe. Yeah? And also Hiddo, you are so engaged in all these trials, but you found the time with us today. So that's great. And of course, I'm so happy if cardiology is with us. So that's my final thank you from the ERA. And Kate, now you do the word, the final word.
Yes, so I was really just going to thank the audience for joining us today, and to thank everybody who submitted questions, because that's really helpful and helps to stimulate discussion, and obviously our expert panel. So Prof Wanner, Prof Tuttle, Prof Agarwal, Prof Marx and Prof Heerspink. We are delighted to have had you on, and thank you, as Christoph said, for making the time to join us. Have a nice weekend, everybody.
Thank you. Bye-bye.
Thank you.
Thank you very much, Kate.